Hi, Hugh.
Hello, how are you?
Yeah, we're good. How are you doing?
Yes, I'm okay, thank you.
Can you hear us okay?
Absolutely,
Yeah.
yes.
Can you?
Um,
Yeah.
Good stuff. I don't think, let me just check. Yes, we do have people joining, which is great. Um, I'm just going to be setting up the chat and the Q&A functions. Do you guys want to see if you can share your screen? Because we had a difficulty with that earlier on.
Yeah, no worries. It says that screen sharing is disabled at the moment.
I thought it might, so it's good that we tried now.
Yeah.
1 second. Okay, Susie, you should be the host now, so hopefully it will work for you.
Yeah, I have got it now.
Great.
Here we go. So I believe I've only shared the PowerPoint screen. Is that correct? Is that all you can see?
Yes,
Yes. Okay. Wonderful. That was pretty easy on tech difficulties.
that that is only the start of it. We'll come later on. So what I will do, because we've got 72 people so far, which is fantastic, and we've still got a couple of minutes to wait. So if it's okay, I will go through a couple of things now. Um, So, to all of you who are joining us, the chat function won't work during this presentation. At the end of the session, I'll reclaim the host, and at which point I can enable the chat. But whilst the actual webinar is going on, we can't use the chat function. So please don't try to, and please don't raise your hand because we can't enable your microphones. What you can all do is there's also a Q&A function. The Q&A function will work throughout the presentation. My colleague Anna and I will try and keep an eye on that as the presenters are going. The other things that we would say is I believe CEUs are available for this presentation. So if any of you would like to claim CEUs, we'll post a link at the end of the presentation. There is an £8 charge for CEU certificates, but you'll also need to remember the two code words. So please listen out for those. We'll go through all of this again at the end of the presentation and we'll make sure that we can share all of the links. But for now, let me see, we are at 11:15, so we're at our start time. I can see we've got 93 people, which is absolutely fantastic. 94, it's still going up. So welcome to everyone who's joined us. Just for those of you who missed what I've just said, there are CEUs available for this talk. Please listen out for the code words. The links, etc., will go through at the end. So the link to claim your CEUs will talk through at the end. And the last thing I'll say for now is that if anyone has any questions at any point, please don't use the chat because it will be disabled, but use the Q&A function instead, and we'll do our best to answer your questions. Susie and Marta, is it okay if I just hand over to you guys now?
Yeah,
Yep, that's absolutely fine. Thanks, Hugh.
thank you.
Much.
So, good morning, everyone, and welcome to our talk about our research into trauma-informed care attitudes amongst professionals working with individuals with learning disabilities who display behaviors that challenge. We'll go through some introductions now. My name is Marta. I'm a part-time student at the Tizard University of Kent, completing my master's in positive behavior support. And I'm also a PBS practitioner for Home Farm Trust, HFT.
Hi, everyone. Good morning. My name is Dr. Susie Mejia Bonano, and I'm a lecturer in intellectual and developmental disabilities at the Tizard Center. I'm also a doctoral level board certified behavior analyst, and excitingly, also now a UKBA cert. Marta and I are presenting this in the realm of her master's dissertation as part of her studies at the University of Kent.
So we're going to start to talk a little bit about the background research that we've done that actually grounded the basis of our research study. So we'll start talking about the trauma definition according to the Substance Abuse and Mental Health Service Administration, that suggests that individual trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So in terms of trauma-informed care, it stems from the notion that every individual, whether it is supported individuals or stakeholders, have the potential to experience trauma, and it recognizes the need to create environments that are supportive and sensitive to the needs of those individuals. So what does this actually mean in practice? So it's about being aware. It highlights the importance of approaching individuals with this acknowledgement, and from everyone, from the people we support to staff, because we actually don't know what people have gone through. It's also about recognizing signs and systems, and this is about being as a system-wide. We can acknowledge and learn to recognize those signs and symptoms of trauma. And that, again, goes for people we support, but also for the rest of the stakeholders. And it's about considering integrating these things into policies and procedures, because that knowledge about trauma will be important, so it's embedded within the whole organization, which then we want to influence professional practice, making sure that professional approaches are supportive of that therapeutical process and do not result in re-traumatization. But is it enough? Well, research suggests that individual circumstances, they need to be considered, and sometimes there may not be visible signs or symptoms of trauma, but we may be aware of some of those adverse life events. So equally, the context of treatment and interventions will influence the outcomes for people who have experienced or are experienced trauma. So trauma-informed care has a set of 4 assumptions within it. First one, realization. It's understanding the prevalence of trauma is high and it can be manifested at different ways. So, for example, understanding that behaviors are challenged as a coping mechanism rather than a controllable event. And we also know from research, for example, from Munton et al. And Standen, that when behavior is seen as controllable, this often will lead to responses that can be avoidant or lacking empathy. It's about recognizing that trauma has a profound and lasting impact on individuals, and beginning to identify signs and symptoms is instilled within all stakeholders, from direct support staff to a CEO directorate level, which then can lead to considering how we're going to respond to those manifestations of trauma. And those responses, they could be empathetic and compassionate, but within the whole organization, which then would lead to resist re-traumatization. So all stakeholders will ensure that interventions and approaches will not result in re-traumatization. So, for example, people that we know that have been victims of abuse, and they may be displaying behaviors that challenge in forms of physical aggression, restraint would not be acceptable. There are 6 key main principles. Safety, which is about creating environments where the person feels safe and protected, and that's physically and psychologically. We also talk about trustworthiness and transparency, ensuring that communication is appropriate and consistent, that being open and honest, and building and maintaining trust amongst supported people and all stakeholders. Peer support can provide understanding and validation, sharing those experiences, and that will promote that recovery and healing. Collaboration and mutuality. Everyone has a role to play, regardless of their position within the organization. And that would come on to that 5th point, which is about empowerment, voice, and choice. Giving people a chance to be heard and feel in control over their lives. And again, this is a parallel process for supported individuals, but also for the stakeholders. And lastly, but not least, and very important, the sixth key principle would be around cultural, historical, and gender issues. Thinking of that inclusive approach, recognizing the impact of cultural, historical, and gender-related factors to trauma. So thinking about trauma, learning disability, and behaviors that challenge. So we know from research that individuals with learning disabilities who display behaviors that challenge are more likely to have endured traumatic experiences and are at risk of developing trauma. Research around the use of restrictions and physical intervention suggests that when exposed to similar conditions under which trauma occurred, individuals can display trauma-related arousal and become avoidant. So being exposed to such conditions, it will reduce that reinforcing value of engagement with other, which then will impact on people's quality of life and can lead individuals to be more at risk of displaying such behaviors that challenge, which then again can in turn lead to additional restrictive practices being put under the individuals and more potential for further traumatic experiences. In terms of access to treatment, the accessibility to suitable treatment is quite limited due to the lack of appropriate assessment tools and trauma treatments that are observable and measurable that are aligned with the needs of the people we support around learning disabilities. So there is the need for service providers to acknowledge these vulnerabilities and adapt practices in order to provide effective support. But we know that staff knowledge is a key element to change practice. And this is particularly important because staff teams, those that are working within the field, they've got the potential to support that recovery process, but equally also the potential to cause re-traumatization. However, we also know that working with individuals who have experienced trauma can lead to secondary traumatization, and staff well-being is actually very fundamental to provide that effective support. So the evolution of this study, it came from wanting to understand what steps practitioners were taking to embed trauma-informed care within organizations. Was there a gap in terms of trauma-informed care implementation and the lack of knowledge around the subject? And it was a great opportunity to research the topic as part of my master's. And after a couple of supervision sessions and jittering, which Susie will go into more detail, we had ethics approval by the Ethics Committee at the Tizard University of Kent.
So just to kind of set the context a little bit more about how the study evolved, it took a really kind of collaborative approach. So Marta was really keen to study this area. For full disclosure, trauma-informed care is absolutely not my area of expertise in terms of the research that I carry out. My area is feeding research and also some kind of behavioral approaches to teaching in higher education. So absolutely not my area of expertise, but Marta was really keen to research this area. So she just needed a supervisor that was willing to kind of help with the development of the methodology and ensuring that we had kind of as much as we tried to have a robust study design, we obviously had some difficulties, so we'll tell you about that as we go on. But really, when we were thinking about how to develop this study to give us, to allow us to answer some of the research questions that we had to have some discussions around philosophy. We had to consider things like our philosophical understanding of why and how behavior occurs, because we wanted to make sure that we were capturing participants that had similar understandings of behavior and the types of things that influence behavior. So we'll talk about this a little bit more on the next slide, but we hypothesized that there would be a difference between people that did and did not have direct experience of training or experience in conducting functional behavior assessments and devising behavior support plans based on those functional behavior assessments. So we thought that there would be a difference between the two groups in relation to attitudes to trauma-informed care on the basis that their knowledge and understanding of the contingencies around behaviors that challenge might differ. So we had to think a little bit about how people understand behavior, how that relates to trauma-informed care and to the measure that we were using. And then we also had some discussions around research design. So that was particularly around ensuring that we wanted to see not just whether there were differences, but we wanted to also understand how the way that people described why they responded in a certain way. So we decided to take a mixed methods approach with this project. So we had some qualitative responses that we were also able to obtain. And the aim there was really to see how people described why they responded in certain ways. And the reason for that is because the tool that we use, the Arctic, has some
Some of the questions,
some
they
of the
quite
questions are,
aligned with the principles of trauma-informed care.
yeah, but it can be quite, some of the questions are quite polarizing. And it really wasn't very clear how somebody that understood behavior as occurring in relation to environmental events might respond when we're also considering things like values-based practice and ethics about related to supporting people with learning disabilities. So we didn't just want to see how people responded on the Arctic, we also wanted to learn a little bit about how people described their responses there. So that's how the study kind of evolved. I'll let Marta talk you through the purpose of the study and what that looked like in a bit more detail.
So a bit like we were saying, the purpose of the study was to collect information about attitudes towards trauma-informed care amongst professionals working with individuals with learning disabilities who display behaviors that challenge. We wanted to compare the information between two groups. So our two groups were made of people that had experience in behavioral analysis of positive behavior support, and we defined those groups as in having training or experience in conducting functional behavioral assessments and devising behavior support plans based on those functional assessments. Our other group would be the people that do not have experience in behavioral analysis or PBS, and therefore no experience in conducting functional behavioral assessments and devising behavior support plans as such.
I will also say here that we asked people to self-identify into either of those groups. So we didn't place them in either groups ourselves. We asked people to themselves tell us whether they had training or experience in FBAs and devising appropriate relevant behavior support plans or not. And we had some interesting responses, which again, we'll talk about a bit later on.
So some of our research questions were how do participants describe trauma-informed care and how does this compare between the groups? The other question was around how do participants describe implementing trauma-informed care in their practice with individuals with learning disabilities who exhibit behaviors that challenge, and how does this compare between groups? And we also looked into how do participant groups compare on the Arctic 10, which stands for Attitudes Related to Trauma-Informed Care. And I will be talking a little bit more in detail about this tool, but we wanted to know how do they compare in those scores as well. So the study, we created this survey online on Qualtrics. We included questions around demographic information. It had some open and close-ended questions around trauma-informed care, some open questions around practice adaptability when working with individuals who may have experienced trauma. We asked also about current experience in practice regarding trauma-informed care, and then we utilized the tool, the Arctic 10, and within that tool, we also asked some questions. We also asked the participants to explain a little bit more about why they scored on certain areas. So a little bit about the trauma-informed, the Arctic 10, attitudes related to trauma-informed care. So this is a psychometric tool that was devised by the Traumatic Stress Institute by Dr. Steve Brown and Dr. Patricia Wilcox and Dr. Courtney Baker. This tool was devised because there was actually a lack of clear operational definitions around trauma-informed care, and therefore they felt that there wasn't any psychometrically robust tools to evaluate it. So this tool in particular, they use a 7-point bipolar Likert scale, and it will compare the attitudes. It will pair them positive attitudes, favorable, with unfavorable attitudes. And you may be able to see on the screen a little bit an example. So for example, we've got supported individuals could act better if they really wanted to. So that would be that sort of unfavorable attitude towards trauma-informed care. And at the other side, we've got supported individuals are doing the best they can with the skills that they have. Now, the Arctic has 7 main subscales. So scale number 1 is about the underlying cause of behaviors that challenge and symptoms. So they look at beliefs about behaviors, symptoms, and adaptations, whether they're malleable versus behavior symptoms as that intentional and fixed status. So an example of some of the trauma-informed care unfavorable attitudes would be the people we sport were raised this way, so there's not much I can do about it now. Whereas if we were to score around the trauma-informed care favorable, we'll be talking about people were raised this way, so they don't know yet how to do what I'm asking them to do. Subscale number 2, it's about exploring those beliefs about the importance of relationships, flexibility, kindness, safety as agents of change versus those rules, consequences, accountability as agents of change. The subscale number 3 talks about the staff on the job behavior, which is about beliefs about that importance of empathy-focused staff behavior versus the controlling authoritarian staff behavior. Subscale number 4 is about the staff feeling of self-efficacy at work. So about beliefs about the ability to meet the demands of working with traumatized population versus that inability to meet the demands. Subscale number 5 talks about beliefs about acceptance of the effects of secondary trauma and coping by seeking support versus minimizing the effects of that secondary trauma and coping by hiding or ignoring that impact. Subscale number 6 is directed more when once trauma-informed care is already implemented within the organization, and it looks at beliefs about being supportive of or confident about that implementation versus being concerned about implementing trauma-informed care. And subscale number 7 is about a system-wide support for trauma-informed care. So beliefs about the system-wide and whereas people may not be feeling supported by colleagues and supervisors. So the 5 main subscales, they were considered to be the attitudes relevant to that implementation, whereas the next 2, they're the 2 subscales that look at the support of trauma-informed care implementation. The Arctic 10 could be used in different sectors. For example, we've got education and human services. Within each of those sections, there are 3 different tools that can be used. We've got the Arctic 45, which is for organizations that have already begun implementing trauma-informed care. We've got the Arctic 35 for those that have not yet implemented, and then the Arctic 10, which is a short form and it's appropriate for organizations that have or not yet implemented. So due to the nature of the study and our inability to know whether participants were in organizations that had or not, we use the Arctic 10. So our study, we started off by trying to recruit participants. So we disseminated our research poster via social media, mailing lists, and it had the Qualtrics link where participants could press and access it. And we asked our participants to complete the online survey that included those open and closed-ended questions with a rating scale. Also, our participants had the option to submit a memorable word, just in case people would change their mind. And as you can see, this is up until the 31st of March, so the research is still live, the survey is still out there. And then at the end, if our participants would like to provide an email address so they can participate in a raffle of Amazon vouchers or obtain results from the research, there is that option out there as well.
I'm just going to pop in here to deliver the first keyword, which is hook. So HOOK.
So the inclusion criteria for our study was that our participants had to be 18 years old or older, living and working in the United Kingdom, and currently working with individuals with learning disabilities who exhibit behaviors that challenge. So talking a little bit about our preliminary results, we had a total of 149 surveys that were open, of which we had 44 invalid responses. Part of our survey, we had some questions that they were optional for people to answer around the demographics, gender, ethnicity. So participants didn't necessarily have to write anything to move forward. But then it got to a stage where we're asking questions very specific around trauma-informed care, and those questions, they were mandatory. So you would have to fill it in order to progress. And out of some of our participants, 44 did not carry on. So that gives us a nice round number of 105 participants in total, and that's what we're going to talk about, is around those 105 participants now. We looked at participants' gender, as you can see, we had majority of female participants. We actually asked participants to describe how they identify. So 80 of our participants identify as female, 22 identified as male, and we had 3 people that did not specify.
Just to also flag, we did collect data around race and ethnicity. And similarly, we, in an aim to be as inclusive as we possibly could be with our research, we allowed people to write in like how they identified in terms of their race and ethnicity. And I think we were really surprised by the results there. We haven't been able to include that here because we haven't been able to kind of categorize everything in an inclusive and comprehensive way for today. But we just wanted to let you know that we have collected that. It flagged some difficulties that we didn't expect in terms of how people self-identify with their ethnicities and such. But it's been, yeah, really interesting to kind of go through that and make sense of that type of data. But we just wanted to flag, we did collect it. It's just not reported here for that reason right now.
We then ask our participants whether they've had experience or training in behavioral analysis or positive behavior support. As an example, we said that yes would mean training or experience in conducting functional behavioral assessments and devising behavior support plans based on such. So the majority of our participants, they said yes. We had 94 participants that said yes and 11 that said no. So we've got 2 groups. However, one of the groups is quite small. So when we're talking about the difference between groups, we're going to be very mindful because of the size of the groups. We can't really make proper comparison. So just be mindful of that. So we did try to address different groups where perhaps we would have more people that would come under the no group. So although we approached direct support staff via social media groups, most of our mailing lists that we had access, they actually involve individuals who have currently or are currently working within the field of positive behavior support or applied behavioral analysis. So we do think that that might have also been a reason why we had a gap in our participants.
Yeah, so it looks like there probably was a bit of a bias as well in terms of actually how we were able to carry out recruitment. And that was certainly not for lack of efforts on Marta's part. It just was a much more difficult group to address and to try to kind of get their views on. And also we have some thoughts about why that might be later on as well. Our participants' work sector, we had people from education, mental health, social care, and some people that didn't specify, majority around mental health and social care. We also ask our participants to describe their role. The majority of our participants that clicked yes for PBS and behavioral analysis experience can see that they are working in roles such as behavior support practitioners, but it was quite interesting to see quite a variety of different roles and also how they would rate whether they had that experience or not. We then ask our participants, what do they understand by the term trauma-informed care? And again, at this stage, those results, they're just summaries and just a little snippet because we haven't concluded the survey, so we haven't formalized the analysis. But within the group that said yes to PBS or behavioral analysis experience, people describe their understanding of trauma-informed care as a framework that takes into consideration physical, mental, and emotional well-being, considers traumatic experiences that have shaped the needs and behaviors, looking at the impact of trauma has on interaction with others, the notion of conscious care based on the awareness of adverse life events, emphasizing empathetic approaches, preventing re-traumatization,
And then in the group of people that said that they didn't have that experience in PBS or behavioral analysis, people also mentioned quite similar things around considering that people may have been exposed to adverse life events. Adverse life events will influence the person's coping mechanisms and current behaviors, which can be challenging to others. And when developing plans, care, treatment, or education, those should be person-centered and reflective of the individual's experiences to minimize the risk of re-traumatization. So pretty similar across. We then ask our participants whether they have received any training on trauma-informed care. So within our group of people who said that, yes, they do have experience in PBS and BA, we've got 63 participants that said yes, and then we had 31 that said no. And interesting enough, on the group that said that they didn't have experience in PBS and BA, the majority said no, with 3 participants that said yes.
And again, we have to be somewhat tentative of those comparisons because we have unequally balanced groups. So we're always very mindful of being really careful with that. But also just to pop in and let you guys know the second keyword. The second keyword is Gaston. So the second keyword is Gaston.
So we asked our participants that said that they have received training in trauma-informed care to describe that training. So for those that said that they do have experience in PBS and behavioral analysis, they said that the training was around face-to-face delivered by psychologists, part of safety interventions, de-escalation and restraint packages, training delivered by BUILD, by the RRN, online webinars, part of postgraduate learning, including doctoral training, and part of continuing education units. For those that said that they did not have experience in PBS or ABA, the training that they've attended was face-to-face delivered by psychologists and community, child and adolescent mental health services. We also asked participants how might they adapt their practice when working with individuals with learning disabilities who display behaviors that challenge and who might have experienced trauma. So in our group that said yes, people were talking about the way they would adapt practice would be around understanding the functions of behaviors, exploring the person's trauma history and share it amongst teams, conscious of triggers and avoid exposing the individuals to such triggers, adapt services to prevent re-traumatization, collaborative work with other professionals, and quite similar views as well on the group that said no to PBS and BA experience. So looking at behaviors in a non-judgmental way, trying to unpick what the person is trying to communicate, being aware of trauma triggers, including staff zone behavior, being empathetic, adapting communication, and collaborative work with other professionals.
So again, really quickly to pop in here and kind of add to this, they're very similar in the responses and some of the things that are being kind of highlighted here. The thing that stands out to me the most about this particular section is the emphasis on trying to unpick what might be going on, like what that person is trying to communicate, or unpicking why somebody might be doing something. So that's something that we focus on quite a lot when we're doing things like function-based assessments. And for people that reported that they didn't have training or experience in function behavior assessments and developing function-based behavior support plans, they were also talking about those kind of similar things. So it's an important similarity to flag at this point.
We also asked our participants whether they were currently working with individuals who have experienced trauma. So for our participants that said yes, they do have training in PBS, we've got 83 people who said yes, but for those that also said no, we had 9 people. So actually the majority of our participants, they are currently working with people who have experienced trauma. What we thought was also interesting just to flag, you might remember from the previous slides that actually out of those 83 people that are currently working with people who have experienced trauma, 63 of them, so 80%, have had training in trauma-informed care. And from our 9 participants, also 3 of them, 33%, have had the training in trauma-informed care. So just to summarize a little bit our participants, because this gets a little bit interesting and could get confused. So we had 105 participants in total to commence with. 94 of our participants said that they have training or experience in positive behavior support and behavioral analysis. 11 participants said that no, they don't have training or experience. Now, from those participants, we had 11 of the yes group that did not continue the survey, did not move on to the Arctic. And from the no group, we had 4 that did not continue. So that gave us 90 participants that actually completed the survey as a whole, including the Arctic. So of those, 83 participants said yes, and 7 participants said no. So next results will be based on those 90 participants. So looking at the Arctic 10, when we're scoring the Arctic 10, we're actually looking at average scores. So lower scores, they indicate unfavorable attitudes towards trauma-informed care. So between 1 and 3, and higher scores will indicate favorable attitudes towards trauma-informed care. So in our yes group, the average was 6.1, then suggesting favorable attitudes towards trauma-informed care. And in our group, the average was 5.8, also suggesting favorable attitudes towards trauma-informed care.
And again, at this point, we have to flag, we had very, very unequal weighted groups. So we had intended to do a statistical analysis to indicate whether there was going to be a statistically significant difference between groups. But because we didn't have enough participants in both groups, we won't be able to do that. We can just provide a descriptive kind of summary of it with the big caveats that we don't have enough people in the no group to be able to kind of say definitively and compare as robustly as we would have liked.
So just a summary of our main findings. So like Susie said, although we can't really make a statistical comparison, so far it doesn't seem like there is a lot of difference between the two groups, and actually they do share similar views in between them around trauma-informed care. So for example, some of our qualitative information focused on awareness of trauma, being mindful of trauma triggers, understanding the functions of behaviors, being empathetic, collaborative work with other professionals, adapting practice. And equally, the scores of our Arctic 10 also showed favorable attitudes across the board. But again, careful consideration when looking at two groups. We also think that maybe some of those results, that may have been a bit of selection bias, because perhaps people were favorable because actually they were interested in trauma-informed care, and therefore perhaps we recruited participants that wanted to talk about trauma-informed care, therefore makes them more likely. And again, it was an interesting number of participants who said that they had training in conducting functional behavioral assessments and developing plans, and that was quite widespread across different roles, and a little bit unexpected, but quite positive to see. And the majority of participants who are currently working with individuals who have experienced trauma have received training in trauma-informed care, but not all. And lastly, just a small little comment from the preliminary results is just thinking of trauma-informed care as a system-wide approach, because at this stage the responses are aligned with trauma-informed care principles and focused on improving quality of life for people with support, but there's not a lot of description around how to implement trauma-informed care as a system-wide approach. So for example, staff-to-staff interactions, supervisor, directorate level to staff. So that's quite interesting from our view to note. So some takeaways and implication for practice. So we know that research suggests that adverse life childhood events and experiences are associated with the development of trauma and traumatic reactions. So we know that individuals with learning disabilities are more likely to experience potentially traumatic events, including physical and sexual abuse, than compared with other groups in the general population. So therefore, acknowledging the prevalence of potentially traumatic experience and the subsequent effect on behavior, it seems to be like a sensible course of action when we're working within the field of learning disabilities and behaviors that challenge in particular. And it's thinking of that our awareness of trauma shouldn't be just diagnostically driven or limited to the implications on the people we support, because one of the major features of trauma-informed care is that the change must happen parallel at multiple levels in the organization. And there's an example from Dr. Courtney Baker's research where actually the results suggested that although trauma-informed care is often focused on improving staff to people with support interactions, the success of trauma-informed care is directly related to improvement in staff to staff and supervisor to staff interactions. So just a little bit there. Anything else to add?
No, that's all the bits.
So that's it.
So before we move on to questions, we just wanted to thank everybody for listening to our presentation today. We've put Marta's email on the slides and mine as well, if you're interested in kind of following up or you have any questions about things. We've also added some references further on in the slides. So we're happy to share our slides as well, Hugh, if anybody would like them.
Fantastic, guys. Thank you so much. I'm sure we will have some questions. We've had a few through already, but if it's okay, what I'm going to do first is just reclaim the host from you, because hopefully we'll then be able to use the meeting chat. So for those of you who were listening for the secret words, we should now be able to post the link where you can claim CEUs into the meeting chat. If you are claiming CEUs for this presentation, there is a charge, I'm afraid. So the conference is free, but the charge to process CEU certificates is £8. If you follow the link, which should be in the chat now, then you'll just need to enter your email address, the title of the presentation, and the 2 secret words, please. The last thing that I'll say before we move back to questions is just that it is a free conference today, but if anyone would like to make a donation to the charity, the Newman Trust, we'd really, really appreciate it. It's a fantastic charity that provides holidays to children with disabilities and special educational needs. We'll post that link into the meeting chat shortly as well. But for now, if we do move on to questions, so we've had a few through already, but if anyone else has any questions, please use the Q&A function to add them in now, and we'll try and go through them. The ones that came through during the presentation, guys, were, the first one is someone was interested in the Arctic scale. So how do you access that? Is it something that's in the public domain, or is it something that there's a charge for?
So do you want to go through what we have to go through?
Yeah, so we would have to access the website of the Arctic 10. It is chargeable. However, for research purposes, we can request a license that allows us to have 200 participants. But yes, it is chargeable, but you can get in touch with the Arctic 10, with the Arctic, and there are the different tools that could be used. So not necessarily just the Arctic, could be the other ones as well.
I should also mention, we haven't talked about this in the slides, but we are actually going to be sharing our results and sharing our data with Steve at the Traumatic Stress Institute. So they are working to try to build up their database in relation to people with, I think people that support people with learning disabilities, so staff. So they've asked us to share our data with them so they can kind of work to validate the measure with that specific population. But unfortunately, we did have to reach out, and they had to, because this was a student project, they allowed us to use it for free for up to 200 participants. So we can't go beyond that.
Fantastic. Thank you very much. Okay, so we've got the next question is relevant to the CEU link, which isn't working. This is becoming a theme of today. So I'm just going to hand over to my colleague, Anna. Anna, the chat function should be working properly now. So if you don't mind posting that for me.
Yeah, I'll do that now. Thank you.
And then we had another question about the Arctic scale, actually. but this was more to do with your data analysis, and as I understand it, that's kind of in progress. But someone asked whether you looked at the difference in Arctic 10 scores between those who had and hadn't had some form of trauma-informed care training.
That is really interesting. We haven't yet finished analyzing. So the answer is actually no, we have not, but that is an interesting question and something to look into, actually.
I have just written this down so you can think about this in more detail as well. This is a great question.
Yeah.
And we might actually have, I was trying to look through the slides to see what the weighting is for people that did and did not, people that said they did and did not have training. We might actually have enough participants to run the stats on that one. So if they're equally weighted across groups. So yeah, we'll look into it.
Okay, great stuff. And in some respects, that's the benefit of presenting on something that's not yet been completed. Fantastic.
Absolutely.
Okay, we've got more questions coming through, which is great. And let me see. So the next question is another interesting one. So what was your interest in comparing groups who'd had PBS or ABA training versus people who hadn't? So what was there kind of a hypothesis that one group would have more awareness of trauma than others? And then in terms of your preliminary findings, is there kind of an indication of one group having more of an awareness than the other?
Yeah, so are you happy for me to take this one? Yeah, so we talked a little bit at the beginning around how we had to think about how people understood like behavior. So we went down the route of thinking about making the assumption that people that said that they had training in functional behavior assessments and devising the behavior support plans that lead off from that, which we understood to be people that have PBS and or ABA training. That they would be kind of aware that obviously behavior is influenced by environmental variables. And that's kind of the reason why we thought there might be a difference between people that had that kind of explicit experience or training of understanding behavior in that way and people that did not. However, we can't really make definitive conclusions because we don't have enough people in both groups. But I think there is more to it. Absolutely. I mean, I think we mentioned a little bit as well that there were some things in there that might relate to values and things like that, and values of how we work with people with learning disabilities and how we view people with learning disabilities. So I think that there's some more things that we haven't been able to capture in this research, but would be really interesting to look at moving forward.
Fantastic, thank you. Okay, we've still got questions coming through, which is great. So let me just see. So a couple of people have mentioned how much they enjoyed the presentation, so thank you guys. Oh, that's an interesting question. So again, I guess this kind of comes back to a sort of different type of bias, but essentially, I'm going to try and sort of summarize. Essentially, what this person is asking, and I do think it's a really interesting question, is the difference in context of where the staff member is completing the survey. So, would you think that there would be a difference in terms of, presumably a lot of people are maybe completing it at home in a nice kind of calm, quiet environment, as compared to if they're actually completing it in maybe a workplace or quite a stressful environment? And I just wonder if you have any thoughts about that.
Potentially there would be a difference, in particularly if we are in that challenging environment, because if we think about it, even our arousal levels during those situations, they will have an impact on the way we can reflect and consider some of those things. So I do think that is quite pertinent and a very interesting question, because perhaps there would have been a difference, and there might have been something interesting to ask participants where they were completing or not, because yeah.
So I've just made a note as well to think about this a little bit more, because I was thinking about it also in the sense of, like, if, for example, staff members had recently encountered an incident that was particularly challenging, how that might influence their responses. And we know that that is something that they are likely to be experiencing due to the nature of their roles. So that'll be something to think about in your discussion.
Yeah.
I was going to say, actually, it's kind of got me thinking, And maybe I'm just complicating matters at this point. And I wonder whether maybe it might have come up in your kind of demographics questions. But I wonder as well about another kind of potential confounding variable being current mental health status. Obviously we're
Mhm.
kind of very aware that the kind of risk of workplace stress and burnout are quite high within health and social care, particularly.
Yeah.
And I wonder whether that was something you'd kind of thought about in terms of how that might potentially influence your results.
Mhm.
Do you want me to
Yeah.
jump in? Yeah, so we weren't able to capture everything that we would have probably have liked to have thought of. I think that there's a lot of scope to do for this to be kind of the like jumping off point for some different kind of areas of research, and maybe some more robust areas in terms of you know, maybe having a survey that does account for as much as we can possibly consider. But we were limited with like resources that we had at the time. It's a master's dissertation as well, so we didn't want to put Martha under too much pressure because she just needs to finish. So you know, we had other kind of things that we had to think about, but it's a really, really valid point. I think like I said, I think this could be a really good kind of jumping off point for thinking about some of those other things as well. Because it's not just, you know, we've captured some information about attitudes towards trauma-informed care. But if you think about it, we've captured that without ourselves thinking about all those kind of contextual things that kind of factor into staff. So yeah, definitely some scope for kind of things to consider and move forward on.
Great. And I guess because we've got some more questions which are kind of come in at a similar angle, I just wanted to be really clear. I didn't mean that as a criticism at all. I more meant an interesting area of research that there's all of these different things that come off it. And I think probably what that indicates is there's a lot of generativity here in terms of it potentially stimulates a lot of other research questions. But the kind of next one, which as I said is in a similar vein, and I wouldn't expect you to be able to answer every single question with one study. But again, it's kind of similar in terms of, you know, thinking about the breakdown between frontline paid carers versus those who work within a management role. And I would think that's probably a kind of similar answer to the previous question, but I'll leave you to think about it.
Yeah, I'm wondering if, I'm not sure that, so where people describe their roles, there's some that described managerial positions, but I don't know that we have enough data to be able to separate that out ourselves. But there are some that kind of describe things like director, head of service, lead education manager, and other people that describe things like trainee and support worker, key worker, an assistant psychologist. So it might be that we might be able to tentatively separate that out, but I think it would be a little bit difficult. But I absolutely think that there would be a difference there as well in terms of, you know, the kinds of considerations that frontline paid carers would be privy to that people in managerial roles might not be necessarily aware of.
Great, thank you very much. The next one's kind of relating back to the Arctic again. And it's kind of quite specific, but again, I'll just read it out to you and you can do your best, which is, so is there a section that compares kind of person-centered approaches, such as staff who know about the person's trauma compared to staff who just have a good understanding of the individual?
I'm not sure within the Arctic that is something that they do compare, because it's more about the attitudes towards trauma-informed care. It doesn't look so much into that person-centered approach. It's quite specific.
Right.
Sorry, we don't know more about that one.
Not sure about that one, no.
Fair, because fundamentally it's a psychometric scale. Okay. Just bear with me 1 second. Okay, so I think you did touch upon this at the start, but I'm not totally sure I understand the question, but I'm going to do my best to summarize. I think it relates to the use of physical restraint and views around that. And then asking what the future will look like with trauma-informed care training. So I might be putting words in someone's mouth here, so apologies if I am. But I guess how I'm interpreting the question is, what do you think the kind of influence of a greater focus on trauma-informed care will be on the training that people are given in crisis management?
Some of the crisis management programs are already incorporating elements of trauma-informed care, and that is it's quite positive to begin to see that, although we are aiming to reduce restrictive practices and in particular restraint because of the long-term effects that we've seen over and over again. But there is beginning to be more and more of a push to include trauma-informed care elements. So hopefully that will be that shift in culture where we're looking at things in a more holistic way around trauma-informed care and being very careful in making such considerations. And we know with some of the RRN standards that now some of those things are being more mainstreamed and people are implementing things differently and being more considerate. So hopefully there will be a shift.
Great, thank you very much. Okay, I was just about to say I can't see any questions, but here's one now. So, okay, interesting. This is more kind of a broad general question about kind of trauma-informed practice. So someone's asked if you're aware of a specific trauma screening tool that can be used as part of a referral assessment. So the example that they've given is a person who's moving from the hospital into a community setting.
Are you aware?
I wouldn't want to specify one tool in particular, but I would advise to look into adverse life events as combined within your own assessments within the organization. But one of the things throughout the literature that is being suggested a lot is around assessing adverse life events, which are different tools out there. But I suppose depending on the context, you'll be able to find which one fits in. I hope that is helpful.
Yes, no, that's great. Thank you, Marta. Okay, fantastic. We don't have any more live questions yet, but we have got about 5 minutes left. If anyone would like to ask any more questions whilst you have the opportunity. In the meantime, I'm aware that some of you have been struggling with links and things still. So what I'm going to do at this stage, whilst we're waiting for further questions, is just bring up the QR code, and then people can give that a try as well. So fingers crossed. You might now be able to see my screen share. So again, if you are collecting CEUs, you can follow this QR code. You'll need to enter the code words, your name, and also the title of the presentation, please, if you'd like to. I am just going to briefly check to see if we have any more questions, but the last thing which I will share before we close the conference room is a QR code for the Newman Trust. So I mentioned this at the start of the talk. The Newman Trust is an entirely voluntary organisation, so it's a charity and it provides holidays for children with disabilities and special educational needs. It is really kind of astounding how far donations go. So, for example, just £25 will actually pay for a riding session for 50 children. So small donations, any amount does make a very big difference. I'm going to bring down the QR code now, just to see if we have any more questions, and we don't, which I think shows how comprehensive you guys have been, so thank you so much. What I will do at this stage is, as I said, I'll just bring up that QR code once more so that if anyone would like to make a donation, they can. And again, thank you very much to any of you who are able to contribute. And so, fingers crossed that is now sharing. The last thing that I'll do then is say thank you to Marta and Susie. We really appreciate you giving us your time. Really, really fascinating presentation. And as I said before, I think a really interesting area of study that kind of opens up lots more questions, which I think again is a really, really good sign of an interesting piece of research, because it kind of shows that actually there's a lot of unanswered questions in this area. So thank you both very much.
Hugh,
Okay.
can I just say one thing before we go? I know some people are having problems paying. If there are difficulties, you can just email Tia your details, and she will sort that out. So if you just need to email her, if you email me, she'll give you some account details, and you can do it by back. So what I'll do is quickly put Tia's email address in the chat. So please email her if you've had any problems paying for your CEUs.
Great, thank you very much, Anna. So
Is it okay? We just wanted to also just thank everybody for all your questions, given us some good things to think
Yes,
about.
really good.
And it's been really nice to get to present to everybody and to hear people's questions. So thank you everybody as well for your time, and thank you guys for having us present today as well.
fantastic.
Thank you.
Susie. Okay, so let me see if Anna has managed to share Tia's email address at this point. And we've got a hand raised as well. So what I'm going to suggest, Lisa, is if you can, and Claire, if you can type your questions into the Q&A box, because we're not able to activate your microphone, but we do potentially have time left for one more question maybe. So it's kind of down to whoever types fastest. Okay, and just looking at the meeting chat, guys, you've got a lot of people just saying how much they enjoyed the presentation. So thank you very much. Here we go. Okay, so a broader question, which I think I've got a feeling you did mention actually. But someone's asking about whether or not they could access the slides, and also asking about your email addresses, whether they can contact you for that. What I would say is for the majority of the presentations today, guys, we are recording them, provided our presenters are happy for them to be shared. We will then be posting them on our website, so please do have a look after the conference. But in the meantime, are you guys happy to share an email contact?
Yes, I can post it in the chat or answer. Which one is going to give it to everybody? Chat, is that better?
Up to you, Susie.
I'll put it in the chat. So I put Marta's email and my email, and we're happy for you to contact either of us with any questions you might have.
Fantastic.
If you do contact me, I might have to refer you on to Marta, because obviously Marta's been in this, and really it's her project, so she knows the ins and outs, but feel free to contact either of us, and we're happy to support as best we can. And I'll share the slides with you later, Hugh, if that's okay.
Yeah, that's fantastic, Susie. Thank you. Okay, great stuff. So I hope you all enjoyed that. We obviously have further talks today, so hopefully we'll be seeing some of you later on. But again, thank you so much, Susie and Marta, and thank you all of you who've joined us, and we hope to see you again soon.
Thank you.
Thank you, everyone. Bye.
Bye.